and Morris. We also have Renee Borowski, Assistant Commissioner at the Department of Human Services. And we have Ariel Scarpelli from MCORTS, MCORTS and PATH Program Director for Mental Health Association of Essex and Morris. And last but not least, we have Karen Wapner, New Jersey 988 State Lead and Regional Coordinator at the Office of Community Services within the Division of Mental Health and Addiction Services. So I'm going to pass it over to our folks in New Jersey. I believe I'm passing it to Karen first, if I'm not mistaken, to start our discussion presentation on MCORTS.
Karen, just before you start, sorry, I forgot to do the PSA. Don't forget that all of our testimony is recorded. Our presenters already know that, but I wanted the participants to know that this is being recorded, so that you weren't surprised if you found yourself posted on our webpage after this presentation.
Thanks, Tiffany. I'm Karen Wapner. Nice to see everyone. As mentioned, I'm from the Division of Mental Health and Addiction Services, the 988 State Lead and Regional Coordinator, which is in the Office of Community Services, where 988 is situated. I certainly would invite Renee Borowski to comment at any point in time, our Assistant Commissioner, who's also joining us in this meeting. And I'm very happy to be joined as well by our esteemed MCORT provider in the North, from MHA Essex and Morris, Ariel Scarpelli and Sydney Asensio. So they'll be talking with us a little bit later. I just want to give a brief overview and then we'll continue to move forward. So this slide talks about 988, the guiding principle. And this is based on SAMHSA's national guidelines for behavioral health crisis care, which includes the core services best practices. And these are also known as the 3 pillars of 988. So specifically, this means that anyone in crisis, as the slide notes, will always have someone to contact, someone to respond, and a safe place for help. And today, just moving on to the next slide, we're here to talk specifically about Pillar 2 of 988, which is someone to respond. This is a newer service. We launched MCORT, Mobile Crisis Outreach Response Teams, effective March 3rd. So we've been boots on the ground now for a few months. And this is the service being implemented for the 988 system, the crisis continuum of care under the 988 Pillar 2. So the MCORT system is designed to respond to adults that need behavioral health stabilization in the community setting without involving law enforcement or emergency medical care. As such, MCORT is designed to reduce the use of law enforcement wherever possible in behavioral health crisis response and dispatches with the intent of resolving crises in the community, again, without needing to involve a higher level of care or service intervention. MCORTs are designed to respond statewide to non-life-threatening mental health, substance use, or suicidal crises. And the goals of the MCORT system are to provide timely access to crisis intervention services, as I said, to stabilize people in their community, in their natural community, prevent hospitalizations and rehospitalizations whenever possible. And like I said, most importantly, or equally importantly, to reduce intervention by law enforcement whenever it is safe to do so during a behavioral health crisis. The 988 Lifeline centers are the only entities able to request a dispatch for MCORT. And this is when a Lifeline center or Lifeline crisis counselor assesses that an in-person response would be of benefit to the individual. The service is completely voluntary and requires the person's consent, right? So they call 988, they're going through an assessment with the crisis counselor from the Lifeline, and the Lifeline Center crisis counselor offers MCORT when they think the person would benefit from that face-to-face engagement. So in order for MCORT to meet, the caller first and foremost has to be willing, they consent to the service, and they must provide a response location because 988 itself doesn't have access to the caller's precise location. So they have to be willing to identify a place where MCORT can meet. Oftentimes it's at the person's home, but it's also important to note that MCORT does have the flexibility to meet in a public setting. So for example, if the caller calls from their home, but prefers to meet MCORT at the coffee shop or in a neutral location like across the street in the park, MCORT is amenable to these kinds of requests. And you'll hear a little bit more about that from Ariel and Sydney, sorry, excuse me. As I was mentioning, MCORTS, the team composition is a 2-person team in the field, which is a certified peer support specialist, which is Sydney, and a bachelor's level crisis specialist who would accompany Sydney as the certified peer specialist. And they are under remote supervision by a clinical supervisor who's usually back at the office. As noted, when we set out here, MCORTS went live March 3rd during weekday hours and have expanded progressively and are now available 24/7. So actually just this week, they expanded to 24/7 services. So every day of the week, every day of the year, 24/7. That's really been something we've been striving for the past few months. Just moving on to the next slide. Thank you. It's important to be aware that MCORT agencies are seasoned in providing a continuum of community services as well as crisis response services. That's something that Ariel can talk a little bit about. MHA Essex and Morris provides a wide continuum of services and is well seasoned in and well placed to respond to crises in the community. Additionally, MCORT staff must be trained in various kinds of crisis response, and they also work collaboratively with other service providers in the community. So the whole effort is geared toward maintaining and linking the callers that they're outreaching to services that are local and can support them to maintain them in their community. Like I said, the objective is to divert from more acute services without involving law enforcement or a higher level of emergency crisis response. I would like at this point to ask Ariel and Sydney to talk a little bit about what to expect when an MCORT dispatches. Ariel, Sydney?
Thanks, Karen. And we can go to the next slide. So once we receive the dispatch, the MCORT teams have 1 hour to respond. We have seen that that's a really realistic response time out of all the dispatches that we've had. We've been typically way under the 1 hour mark because our teams are really getting the information and going out immediately. But that does depend on like the location and the time of the day, how close we get to that hour. But of all the dispatches we've had, we have not exceeded that 1 hour expectation. At the time of dispatch, we also have a lot of information at our fingertips. We get information from 988 about a summary of that call, what precipitated it, any contributing factors, any suicidal or homicidal ideation, and also just basic information like their name, their age, the meeting location or their address, and their phone number. And at that point, when we get that information and we're on our way, we do call the individual. And that's our point to kind of just build that rapport already. So we're introducing ourselves, what our team members' names are, who we are, what time we'll be there, and get some other information if we need it, like building codes or what would make them most comfortable when we got there and how we can connect with them when we get there. Do they want us to ring their doorbell? Do they want us to call them? We want to make this as easy as possible for them and also as comfortable as possible for them. And our teams do arrive in plain clothes in a nondescript car. And we do that again to make the person comfortable so that we're not bringing any outside attention to us, that there's a crisis service at their home, to neighbors or other individuals in the area. And I'm going to pass it to Sydney now, who's going to share about what it looks like when we're physically there, because Sydney's the one doing the work. So she's the best person for the job.
Hi, everybody. My name is Sydney Asensio. I just wanted to thank you all for this opportunity. So more about the program. So when we get there, obviously we call upon arrival. The individual is there. Sometimes we collaborate with family members. There's either caregivers, loved ones, whoever's there, even the caller. We've had a couple people even that were in parks that would like to be serviced there, not away from the home. So I think this is a tool that MCORT gives us is, people want their privacy. People don't, really want too much of law enforcement. And it's also, at no cost. I know a lot of people are worried about, hey, I need mental health treatment, or I need somebody to talk to, or I need talk therapy, and I can't afford it. I don't have the insurance, or I don't know where to go. So I think this is an essential tool that a lot of the communities have and could also have in several states. Do you want me to go into the dispatches also?
Yeah, please.
Okay, so we had two dispatches in the past. One was high risk, one was a low risk. We had a young male, part of the LGBTQI plus community. He was a DV victim. He was fleeing during that time. He had no support system, so he was, like I said, fairly young. He was in need of immediate support. He was actually high level suicide risk when we got that call. Like, he had history. We had, still current SIs. We still had a feeling like he would get through this. We had the hope, but when we got there, after 45 minutes of de-escalating motivational interviewing, still he was presenting as high risk on the suicide assessment that was conducted, and then we collaborated with the individual to get him to a crisis center, which he was open. He actually was very thankful and very grateful. Like, if you would see it, like, you could see like he actually needed, he wasn't opposed, he wasn't resisting, he wasn't fighting it. Like, he really needed that, especially at that time. Like, I felt like, if we wouldn't have made that call, I don't know, but I'm just so thankful that we did, and he was open to it. But mobile screening didn't come out, law enforcement didn't come out. He was warmly handed off, there, who did the admission process. So, and it was at a hotel. So we didn't want to attract all the attention, especially how he was feeling. We were trying to be conscious about, how he was feeling. We didn't want to air out anything that was going on. And then we had a low risk case. It was a young female in her late 20s, no history of SIs or a current plan, but she was struggling with grief from a miscarriage. She had low support from her partner. She basically needed a safe space to vent to. And you can see that these cases are very broad on the spectrum, with high risk, low risk, but she just needed a safe space to express her feelings. She was very accepting of our suggestions and resources. During the next follow-up, actually, she took the initiative to do her own research on the research we provided, and she was ready to receive the support and, start the process going. So I just wanted to close it up by saying these dispatches are very case by case. Like, you would see individuals in the communities struggling with housing or employment or needing treatment, and some individuals that are just really going through it in the moment that just need somebody to just listen to their emotions, and there's nothing wrong with that. So I just very grateful for this program. Thank you.
And I think what we see on the dispatches is that we try not to leave any stone unturned, right? Like, if whatever the factors are that are contributing to the crisis, we try and resolve them all. Maybe not the first day, but that's the great part about having the follow-up ability, that we're connecting with them again. If there's anything that wasn't a priority that first day, we get to focus it on the second day. We've had instances of individuals who were facing eviction that we were able to overturn the eviction by working with the resources in the community. So just really working with the individual and prioritizing their needs, and then anything that we can accomplish, linking them to the appropriate services so that they can continue to receive assistance moving forward, and warmly hand them off the best we can. But I want to pass it back to Karen so she can talk about our regions, because there's a lot of different teams across the state.
Thank you so much, Ariel and Sydney. I just wanted to mention the things that Ariel and Sydney highlighted are really, really good to point out, because you can tell from the way they're sharing information that they're really focused on meeting the individual where they are in the community. And while some people do need hospitalization that MCORT outreaches, just having MCORT involved makes it a much more comfortable experience for the person who's needing help. So I think that's really helpful to point out. MHA has had a number of those circumstances, but also an equal, if not more so, number of just being able to maintain someone in the community setting and just provide the resources and those wraparound supports that really exemplifies MCORT and why it's so helpful. So as Ariel mentioned, we have 9 regions across the state. That's how we've divided the state. So 9 regions, 5 providers, and 62 teams for 24/7 services. Region 1, 2, and 3 is the southern part of the state, and that provider is Legacy, as you can see here, 1, 2, and 3 in the south. Then we have regions 4 and 6, which are Monmouth and Ocean, Monmouth and Ocean, Middlesex and Union. Sorry about that. That provider is Collaborative Support Programs of New Jersey, or CSPNJ. Then we have regions 5 and 7, Hunterdon, Somerset, and Warren, and Morris and Sussex, covered by Bridgeway, and region 8, Bergen and Passaic, which is Care Plus. And region 9, last but not least, is MHA, Essex and Morris, which Ariel and Sydney have just talked about. So this is how the region is, the state is divided up into regions. We've been becoming more and more active since launching on March 3rd. Again, we are now active 24/7. And we hope to continue to see more and more outreaches. It has taken a little bit of time for MCORT to catch on. The Lifeline Centers historically have been able to manage crises of callers calling in. So MCORT is another sort of tool in the toolkit that was not previously available. So it's been a learning curve, but the Lifeline Centers and MCORT providers meet with us on a weekly basis. We talk about collaborative efforts, ways to get MCORT out there more and more, and we are sure that we're just going to see increased outreaches from here forward. So we can just kind of move to the next slide, which is just to kind of wrap up in summary. As I mentioned, MCORT is currently available statewide 24/7. MCORT is strictly accessed by calling 988, which is the nationwide 3-digit dialing code for suicide prevention and mental health or substance use crisis. And lastly, you can call, chat, and text 24 hours a day, every day, by doing call or text to 988 or chatting at chat.988lifeline.org. Thank you.
Thank you so much. And I have just some questions here to get at just some additional information out for folks about the value of hiring peers for MCORTs and why that was a intentional design for the team. And if you could speak more to that, Karen, and of course, Ariel and Sydney, if you want to jump in on that. We'd love to hear more about that.
Yeah, thank you so much. That was very intentional. That preceded my time as the 988 state lead, but I know that that was very intentional by design because we wanted to make sure that persons with lived experience were really first and foremost and can often lead when they're out there in the field. So I certainly invite Ariel and Sydney to chime in here based on their experience.
I mean, just like overseeing the program, hiring peers and having the peers out there, they really have been the rock stars. Like I say it every time we have a dispatch, like they are just tremendous out in the field. And just being able to look at crises in a different light with their lived experience and being able to connect with people in a different way has been so valuable, I think, for the individual we serve, but I think for the teams just as well. Like I hear from our bachelor's and master's level staff how much they're learning from our peer staff. And not that I didn't expect that, but it's been like the response has been so overwhelmingly positive. And I've just had such a great experience, like just being a supervisor over so many new staff that have lived experience and learning so much from them. So I don't know, Sydney, if you want to share a little bit about it's like to be a peer in the program, but it's been great to see it happen in real life.
Yeah, I just wanted to say that this role, especially in this program, but with all the encounters and the dispatches has really, obviously when you hear about peer, there's lived experience in any, part of their life. So all my hard work of, trying to get a job, going to therapy, healing, whether it's my addiction, mental health, whether it's trying to get employment services, career readiness, like I've been through the whole spectrum. And it's like my hard work has come into fruition to pass that on to like people in the community that I love, which is my people that this is like my way of giving back. And I still to this day have ties to the community. I still volunteer on weekends, even when I'm not work. Like it's my passion. I feel very valued in this team to be able to bring my own skills, my own knowledge, whatever that looks like. It may look different for everybody. People may not understand this role or, why there is, but I think that we bring values just as much as, anybody in this program. And yeah, I just want to say I'm really grateful that I can, you know, pass it along to people that have been in my spot right now. And it's, you know, even if I don't understand that, maybe I haven't been in that service, but I can definitely have empathy, and, you know, we'll figure it out. We'll meet you where you're at, and let's get you rolling on the next part of life. So thank you.
Thanks. And then that was a good segue, Sydney, about the value of community. And if you all can speak to um, the value of contracting with agencies that and specific MCORT staff that reflect the community that's being served in the different regions. If there's been any, like, what are the strengths of that? And then have there been any challenges with recruiting MCORT staff from impacted communities?
So I'll start, and certainly Karen and the MHA team feel free to jump in. The Division of Mental Health and Addiction Services, probably decades ago now, included language in all of our requests for proposals for new services that requires applicants to talk about how they will hire, so recruit and retain staff that are reflective of the communities that they serve. That's critically important. It has been, as I said, for decades, with our contracting, just as critical as the peer piece. And so supporting a certified peer workforce is something that the Division of Mental Health and Addiction Services supports as well. And so providing opportunities and reimbursement and support for peers who are currently in the certification process is something that the division has done as well and will continue to do. Karen and Ariel and Sydney, if there's anything you'd like to add, please feel free.
Thank you, Renee. Yeah, I mean, you said it, you summed it up perfectly. I would ask Ariel, Sydney, Ariel specifically to respond just based on, you know, staff you've been in the process of hiring. I know we have had some challenges with covering all shifts, but MHA Essex and Morris has done a great job in making sure that all shifts are covered. So Ariel?
Yeah, I mean, there's always gonna be staffing, you know, issues, but I think, like, especially for us, like, we've been like a household name in Essex County, but Hudson County was the first program. This is MCOR's the first program we've had in Hudson. So we were really conscious of, like, Hudson County looks a lot different than our other counties that we serve. There's a larger Hispanic population, a larger population that speaks Spanish. So we try to find staff that obviously were first best for the job, but also reflected those needs. And if they worked or lived there previously, that was like an added bonus. So we did try and pull and find people that already were familiar with that community, since we actually weren't, right? That wasn't our bread and butter. Where Essex is more of like our bread and butter. We've been in Essex for a really long time. And just like, we try to find a really wide range of like skill sets. We have staff that are as young as 25 to as old as almost 70. So we have a very wide range of age ranges. We have staff that are veterans, that are part of the LGBTQIA plus population, that have different skill levels with case management, some that have worked in unhoused populations, some that have worked in screening. We have some supervisors that were co-responders with police departments before. And we also have some staff that are certified in really unique things like Reiki and like tapping techniques like EFT. So I think our teams are so diverse in so many different ways that basically when we see these dispatches, I think we did a really good job of like figuring out our staffing too, that like, you know, when we got a dispatch like someone like Sydney talked about where someone's experiencing a miscarriage, we have a good handful of male staff, but also female staff. So we might not send our male staff out to that one. We might send our female staff out instead, and really get to look at like who we're sending out to these dispatches, and kind of cherry pick a little bit of who we think can better respond to each and every single dispatch, so that we know we can better serve them.
Great, and I know we're kind of a little over time for this section, but I do want to get at just discussing opportunities for collaboration with community crisis response teams, CCRTs, and put like where you kind of see potential for that as they're, you know, approaching and working on implementation. If you can share where you see those opportunities in the types of calls that you've been responding to since March.
Thank you, Felicia. Yeah, that's a good question, and it's something that we're really intent on continuing to work out collaboratively. We did meet, certainly we've met ongoing with Tiffany and her staff, and we had an opportunity to meet with one of the CCRTs, and that same team from Newark also spoke with Ariel to talk about, future collaborative efforts. It's a little bit different because MCORT is accessed very specifically by calling 988, right? So it's a question of how would that work for those municipalities where a CCRT is located? Would that be something that the CCRT can then get involved sort of after MCORT is kind of closing out in follow-up, and there would be some kind of collaboration at that point? I think these are things that we're still trying to identify as far as the appropriate intercept. But certainly we're open to always working collaboratively. Ariel, would you like to say just a few things about your conversation with Newark?
Yeah, I mean, when we talked, it seemed like the services are a little similar, right, in terms of like how they can respond, except ours is so specific. You know, ours is very short term, and we're really working to warmly hand off people to longer term services. So I think, like Karen said, like at that point, if they maybe needed a little bit more hand holding beyond what our initial dispatches and our follow-up looked like, maybe that would be an opportunity for us to collaborate. I think we're always open to collaboration. All these services exist and we all want to work together because we're all here for the same reason, which is to provide the best services to the individual, and whoever is the best service or best need for that individual is who should be working with the person, right? It's not our person or your person, right? We're all here for the same purpose. So whatever that looks like, we would be happy to collaborate in the future.
That's great. That's great to hear. And we look forward to discussing that more and seeing more about like kind of building out what that looks like. And last but not least, I do want to hear more or have folks hear about what you all do for employee wellness and retention and how you take care of your folks and your teams.
MHA is an agency. I mean, we have things like employee assistance programs, 6-month retentions, of staff appreciation breakfasts, kind of like the normal things you typically would see. But I think the MCORT program, especially for me, like I've come from like homeless outreach and different programs, like with having peer staff, I feel like the supervision and level of attention that we're providing to the staff and checking in and making sure that they're okay is really different than previous programs that I've overseen. We debrief after every single dispatch, check in with the team, see how they're doing. And I think like doing like unique training exercises has really been helpful in keeping staff like happy and, like feeling like they're cared about and appreciated. Next week, we're kind of putting our team meeting agenda to the side, and some of our staff are going to share about some breathing exercises that they find really helpful for themselves and teach the staff on how they can do them for themselves. And maybe that translates over to the future of something they can teach the consumers that they see out in the field. So I think just trying to be really creative and unique with like how we're supporting our team each and every single day is a little bit different than how it's run in like, your typical case management program where they're out there seeing clients, like 30 plus clients a week. So I think it's a nice change of pace to feel like we're providing a lot of support to the team members.
And Karen and Renee, do you have anything else to add to that before we transition?
Karen, did you want to talk a little bit about the TTI, about the
Sure, yeah,
grant that
thank
we
you.
received? Yeah.
Thank you, Renee. Yeah, along those lines, Felicia, we did receive a technical transformation initiative grant from NASHVID this year, and it's in that very area of the crisis workforce and wellness. And so we've been meeting with what we've nicknamed the TTI Advisory Coalition, which is comprised of representatives from the Lifeline Centers, from MCORT, from our dispatch managing entity. And we've been meeting now for the past couple months to come up with trainings, wellness activities, things that Ariel kind of mentioned along those lines that we can then turn around and offer back to the workforce. And since the coalition is comprised of representatives from the workforce, they're really well positioned to identify trainings and wellness activities that would be really helpful and meaningful. So we do have a good long list of trainings, potential trainers, a good long list of wellness activities. We're in process of implementing a Survey Monkey to disseminate the professional quality of life survey as sort of a pre-survey, and then we'll do a post-survey at the end after we get training and wellness activities scheduled. But we really do care about our workforce, as Ariel said, and we just want to make sure that they're very, very well supported in the work that they do. So thank you.
Yeah, that's so important as they're pouring into others that they're also being taken care of. So thank you for speaking to that. I'm going to pass it over hopefully to Anne. Hopefully Anne's able to unmute.
I hope
and
so.
introduce- Oh yeah, there you are.
Yay! Thank you, Felicia, and talk about support. I want to thank my colleague Felicia for jumping in as I was panically trying to get onto this Zoom. That is what collaboration and teamwork is all about, Felicia. I really appreciate you. But I'm Ann Larson. I'm from the Council State Government's Justice Center, and I'm really thrilled to introduce Dennis to this conversation. I'll let Dennis talk about himself, but what I will tell you about Dennis that you cannot read on a slide is that we had a learning community last year around substance use and overdose response through our partnership with the Center for Policing Equity. And Dennis and his colleagues in Ohio showed up to every meeting. They engaged, they had their cameras on. Every time we email Dennis, he emails us right back. And I'm thrilled for him to kind of provide his perspective of what's happening in Ohio and kind of riff off of all the conversation that he's heard earlier from our amazing MCourts presenters. So Dennis, without further ado, I will turn it over to you.
Dennis, you're muted.
You guys missed some really good stuff there. That's for sure. Sorry about that. Listen, thank you so much, Ann, Felicia, for the invitation to be here today. And to the folks in New Jersey, what a privilege it is to get to spend some time with you. And I love everything you guys are doing with MCourt. That is fantastic. We have some similar mobile crisis response teams here in Ohio, and I love what you're doing and all of the things that your programs mean to the communities you serve. So, yeah, my background's in law enforcement. I spent 41 years as a police officer, with 37 of those or so in drug enforcement. And I worked with the Ohio Attorney General's office for a number of years. And the last 10 years before I retired and came to work for the Ohio Department of Public Safety, I was a commander of a multi-jurisdictional drug task force located in South Central Ohio. And in 2015, after 30 years in drug enforcement, I went, we got to do something different. So in 2015, we created what at that time was basically a QRT, a quick response team, but has evolved into really a full-blown deflection team. And we embedded a peer supporter working with a police officer into my drug task force. And I'm really proud now that here in Ohio, we have 45 multi-jurisdictional drug task forces. And out of that 45, we have about 30 that have some connection to a QRT or a deflection team in their jurisdictions. And we have a dozen of those that have teams embedded into their drug task forces. So we're kind of looking at drug trafficking and substance use in a more, I think, comprehensive way here, and how we're addressing those challenges in our communities. So yeah, that's a little bit about my background. Do you want to ask those questions, Anne, or you want me to just kind of start talking about those?
What works best for you, Dennis?
All right, go ahead. Well, however,
All right.
you tell me, you lead, I'll follow.
Well, can you talk about, I mean, I think you reference it, but like you saw in 2015 that you needed to do something different, right? And, you looked at embedding peers in these deflection programs. So how do you look at the gaps? Like, so right now we've listened to MCourts, we've got these CCRT teams coming on, there's other teams that are responding in New Jersey. How do you break down those silos and look at those gaps and figure out how to best serve your community members?
Yeah, that's a great question. And so, from our perspective, which was a law enforcement led deflection team, we certainly recognized where we had some barriers and challenges and gaps in the system. But I knew that wasn't a comprehensive or broader, as broad a perspective as we needed to really serve the clients and the community members. So we really pulled together all of the potential stakeholders in our community, to include community members, and sat down and had a lot of frank discussions about where are the gaps in what we're doing. And everybody's doing great things. They're all well intentioned, but sometimes we miss the mark. And so we were really honest about where those gaps existed. I think the really key piece, though, was when we brought in people with lived experience, and we had conversations with them and said, where are the gaps? What are we kind of blind to? And they really opened the aperture for us and allowed us to see things in a more complete way. And once we saw where the gaps were, then it was a matter of prioritizing those and which ones of these need fixed immediately, and what's the best approach to do that. And we didn't try to eat the elephant all in one bite. We took a lot of small nibbles at it until we got it accomplished. But the one thing I was really proud of was we all committed as a group across these multiple disciplines to kind of not take no for an answer, and where maybe institutional or bureaucratic barriers might have existed, we've figured out ways around those things. So I was really proud that we did that. And I think and we're constantly evaluating the process too. So those teams here in Ohio, and we have about 100 deflection teams now across the state, and another, I don't know, 25 or 30 diversion programs that are working in concert, not only with law enforcement, but behavioral and public health entities across the state. Is we're really constantly evaluating and looking at what we're doing. And as new technologies emerge and new processes emerge, because we're a home rule state, so we have 88 counties in Ohio. And if you've seen one deflection team in Ohio, you've seen one. They all look a little bit different. They all operate a little bit differently. So we're really careful to pay attention and try to continually look at our processes and where those gaps, new gaps might have appeared, to address them.
And I think that we know that partnerships and collaboration doesn't happen overnight. Doesn't happen on a screen. It doesn't happen with
No.
a report. So can you talk a little bit about how you built trust and collaboration
Yeah.
in the teams working amongst themselves and with traditional first response?
Yeah, for the first step in that was to know that we needed those other partners, that we couldn't do it alone. Law enforcement, I think, is tasked across the country with a lot of responsibility to in many cases that people want or think they need to be everything to all people all the time. And I recognize that that's not a realistic approach, and that I needed community partners. And there were people in the community that were working in that same space, so to speak, trying to address these issues, that knew way more about this than I did as a policeman. So it was really bringing all those stakeholders to the table. And for me, it was really being humble enough to go in and say, I don't know what I'm doing here. This is the vision, and trying to explain the why, and asking them how I could help them, not so much how they could help me. And I've seen, some teams, I get asked this question a lot. They'll approach it from, hey, we want you to do X, Y, and Z. And here's why, it's a really cool program. We need you to do this. And people are generally resistant to getting, new assignments and new tasks and all these other things. But when somebody comes in and offers you a hand and says, what can I do to be helpful to you? And so we figured out ways that we could be helpful to them first. And I saw that as an opportunity to build trust with those organizations, because I think there are certain stigmas, sometimes professional and institutionalized stigmas, that exist in various professions that are oftentimes not warranted, but they're there nonetheless. I certainly had, preconceived ideas and thoughts about what behavioral health people did and how they went about their business. And I'm confident that some of them had ideas and thoughts about law enforcement. I know there were a lot of people like, what's this guy really want? What's his real agenda here? And so it was a very intentional act to try to help them on other things that they needed, and then introduce the idea that we had about this law enforcement led deflection team and how we could get this thing going.
Yeah, thank you for that. You mentioned Ohio and the counties, and that every county looks very different. And I think that is rings true for New Jersey as well. And it rings
All
true
of
for
that.
my home state, Washington State. And so
I
when
was
we
just on a
are,
call with them.
I know. And so when we are tasking like states to like look at something, how do we, and we know that like real impact happens locally. So from your lens, working at a local level, and then from your lens at a state level, like what are your thoughts on how to support local communities in these programs, but you're positioned at a state level?
That is a great question. And, from my perspective, I try to approach all those conversations with my local partners from, again, a humble position. I'm not the state. I'm not here mandating anything. I'm not telling you you have to do any of these things. Here is the way that here are the things that we have that we can be supportive. Tell me what you want your program to look like. How can we be helpful to you? How can we support what you're doing? Um, and allowing them to kind of drive the bus. I think the more local control you give people, the more voice you give them, and the more they see that demonstrated through action, the quicker you build that trust and allow them to really embrace participating in these kinds of really dynamic programs.
Awesome. All right, I have another curveball for you.
Let's
So,
go curveballs.
um, I think communication and messaging is really hard. So I think that, community members knowing like, oh, why would I call M-Courts, or why would I call Arrive, or when should I call this or that? And then also like among the other, like all of these teams. So is there an approach that Ohio has done that is like builds the trust and confidence amongst the teams of like, I know an M-Courts team has these skills and resources and authority. I know that this team has these skills, resources, and authority. How do you all know what your role is, what you do, and the roles of what all the other players in the system do? And how do you communicate it to the
Yeah, again,
community?
yeah. So, the first part of that is, how do we work and collaborate with these multiple disciplines and these various teams? It really came down to open, honest communication, and luckily, at least here, that started in 2014 for us, so long before COVID and the screen business, which I'm grateful for this technology for sure. It's opened up a whole new way for us to communicate. But I still find incredible value in sitting down across a table from somebody and them, being able to physically read your body language. And but it was lots and lots of communication on the front end. It was people agreeing on a common vision and a common goal. So that was really key too, So what are we all trying to accomplish here? And, once you tell somebody, I don't care who gets the credit. You can have all the credit. You can stand up in front of the media and do all of that. We just want to serve the public and do what's in the best interest of our clients. So that was really helpful in terms of communicating with the community, messaging to the community. Super intentional, very purposeful. Every opportunity we got to be in front of community members, whether that was some little town's, community festival day, or a county fair, or a drive up naloxone distribution in a Kroger parking lot, or whatever, any opportunity we got to get media, social media, and physical presence in front of the community, we were there. We were at churches. We were at, township trustee meetings, talking to the community and explaining the why it was important to them, why it was important to us, why it was important to the constituency. And once we started explaining the why and people understanding that fixed a lot of those issues for us. And and when as somebody that works for the state now and going into those local communities, it's it's being honest, it's being humble, and it's being honest, and it's being supportive and demonstrating that through actions, and not, kind of like, well, I know my bosses at the Department of Public Safety would really love an opportunity to have a big press conference here and stand up and tell, the folks all the wonderful things we're doing to support the local communities, but that's not what the local community needs. What are their needs? So really understanding them and listening to them.
Great. Okay, I have two more, and then I know that this group will be engaged in some conversation with all of our folks that spoke today. But you have been
Cool.
doing this for a minute and through a few
Yeah.
political changes and administrative changes. So how do you stay the course? I mean, how do you stay the course during administrative
Yeah.
changes at state level, at the local level, at every level?
Yeah, I don't know why you would bring that up. That's weird, but okay. Um, for us, and we're about to go through that type of change here. Our governor's got about a year left in office, and then we're going to get a new governor. And so I think you need to be very intentional. You need to be paying attention to these things and not, blissfully unaware. So, you know, paying attention, trying to read the tea leaves a little bit and kind of anticipate, okay, this guy's likely, going to be the candidate for this party, and this guy's going to be the candidate for that party. And we're trying to figure out how do we get relationships? How can we get in front of, folks associated with those particular candidates or campaigns and start having conversations about what we're doing and giving them the why and talking about the progress and why this is important. And, for us, we're really blessed because we've had some really amazing research done here in the state of Ohio on deflection programming and how impactful it is, not only in terms of reducing the number of encounters with social services in communities, but the cost savings associated with Medicaid. So, in some community, Dayton, for example, which is a mid-sized city here, um, through engagement with deflection teams, they saved the city of Dayton $13 million last year, which, that's a pretty big number when you take that out across 88 counties or an entire state and see what that looks like. So it was really about kind of really looking for ways to have relationships and talk to those people and really thinking about and today with the changes that we see, I just saw something this week where there was some language in a particular grant we were looking at that didn't want necessarily uh, things related to harm reduction mentioned or done. And we know how beneficial that is. We're not going to stop doing that. So you know how can we find workarounds for those things or potential solutions without violating the trust of the folks that are funding us or providing that money. Do we have alternative funding sources that we can go to that don't have those same restrictions? So it was really about just trying to identify those other approaches, and I hate to say in being politically savvy, but you kind of have to be. And somebody in your group, somebody in your organization has to be paying attention to those things and mindful of those.
Yeah, thank you for that.
The
One of
more
the
data you have, though, I think the better you're prepared to do that, right?
and Ohio has an
So,
amazing
I'm sure.
dashboard.
Yeah, we really do. We've got a number of different data sources, and man, it has been, and everybody's on the same system, which was really beneficial for us. So we were able to get all of our deflection teams on one consistent case management software system. So, and we built a consistent language model too for all the deflection teams across the state of Ohio, and we're incorporating that through state agencies now, so that when we're talking about deflection, for example, everybody speaks the same language, which is a huge, as you can imagine, that's often a huge barrier.
Yeah, it's a huge barrier
Sorry.
in no, it's so true. I have a sub commission and we spent 2 months creating a definition. So it's super important to have common language,
Yeah,
common data
for sure.
points. I totally appreciate that. I have one more question for you and then we can open
Please.
it up. But I think that one of the things Ohio does with your deflection group is that you do have that association. And I think that bringing
Right.
people from across the state together, having a formal association, the deflection association, having a convening where people can come together, talk. It's good to be able to go someplace and meet with folks that are doing this similar work and not be a subset of like a law enforcement conference or convening or a subset of an EMS one, to have your own space. So can you talk a little bit about your Ohio deflection?
Yeah, so in 2019, I got together with a couple other law enforcement guys that were passionate about deflection here. And we said, you know, deflection is way more than just us. It's all of these other disciplines. And we, you know, as cops, we have the Narcotics Officer Association and the SWAT guys and the, you know, detective guys and all that. And I'm confident these other organizations have similar associations for their, you know, kind of niche you know, professions. So we need to get all these folks under one roof, under one umbrella. And have one voice. And we felt that, you know, for a couple different reasons, it was a more efficient and effective way to share information and collaborate. And it was definitely going to be more impactful for us when we had to sit down and have conversations with, you know, legislators and policymakers about these types of programs to have that voice. And so in 2020, we kind of created this Ohio Deflection Association, and we brought together some key people from all the different disciplines, and that we had the same kind of vision, same voice. You know, they were passionate and excited about deflection. And we brought them all together and said, hey, this is what we're thinking about doing. And we were really blessed that a couple of these folks had been in other types of professional associations and helped us build kind of our policies, if you will, and our our bylaws. And I think the biggest thing we did was we gave everybody a voice, like a real voice, not just, you know, hey, you have a voice on paper, but you know, the guy from the cop's going to lead the conversation and you don't get to say anything. These folks actually have a voice, and that included people with lived experience, behavioral health, and hospitals, and fire and EMS, and the community. It's been incredibly successful to have that network now that really is kind of leading this initiative in the state of Ohio, and state government kind of backed that up. So, in addition to the Ohio Deflection Association, which represents all of us now under one umbrella, we also have a deflection center of excellence that the state put some money into to work with the ODA to build, you know, best practices and establish a more professional foundation for what we were doing. And really proud of the work that is going on here. And you know, in addition to our annual summit that we have with the Ohio Deflection Association, we have a monthly ODA call where hundreds of people from across the state that are involved in this work gather for an hour, and we talk about what's happening with deflection across the state of Ohio, and we give people opportunities to ask questions and talk and share current information. Yeah, it's really proud of the things that the ODA has accomplished. You know, we went from three guys having this dumb idea over dinner one night to last year's summit. You know, we had almost 20 states represented there at the summit. And, you know, now legislatively, we have a voice. We were able to get deflection put into our state budget this year, which is just kind of unheard of, that we got some kind of crazy program like this put into the state budget where the funding's locked in. And so we have a voice there, and we have a voice now in DC. And yeah, really proud.
We should be. Decisions over dinner that lead to sustainability of programs is pretty impressive. So
It's pretty cool. Yeah. And that was, I don't know that we were thinking that far down the road. We just knew we needed a consistent voice for everybody. I don't think any of us thought that it would get to where it is, but that's the power of bringing all of these different disciplines and perspectives together. And I can't tell you the number of times we've been in meetings and, you know, I'm seeing things through my lens, and you know, somebody in the room with lived experience or somebody from the hospital will say, hey, have you thought about it from this perspective? And I'm like, oh my gosh, no, I didn't even know that was a thing. And now I know that's a thing. So there's this constant learning and cross training, if you will, across the disciplines, and building mutual respect and admiration. And it's really powerful.
I couldn't agree more. Thank you so much, Dennis. Please stay on if you
Oh,
can. No, folks. Okay, of
yeah,
course.
for sure.
Of course, you say yes.
Yeah.
I'm gonna pass it to Felicia real quick. She's gonna pull up another slide or two, and then we're gonna open it up for questions.
Thanks, Anne. I just wanted to share this slide as food for thought for our ongoing meetings. This is a snapshot, if you will, of New Jersey's ongoing crisis response options and timeline of all the work that continues to build and grow off of each other. As you can see, of course, this does not encompass everything in New Jersey that's available for crisis response. But we do want to just, again, have this as food for thought for future meetings and talking specifically about how, like, what are gaps that exist and how CCRTs can help um, meet what's needed in the community and how we can kind of weave all of these responses and options together and just coordinate better in the state. Um, so I just wanted to share this again. We'll share it again in October and just have more of a guided discussion, potentially specifically on like opioid response teams and that work, and just again how this work continues to build and the funding versus implementation, and how things just like Dennis was saying, takes time, right? It takes that dinner conversation that leads to another meeting that leads to and what we're doing in that time and how we're being able to support these efforts in the community. So again, just wanted to share this. It'll be available again in our next meeting. And I just want to encourage you to come with questions or ideas for that discussion about, again, how CCRTs can help address gaps and what's missing from this timeline. We'd love to learn more because we're not aware of everything as well. We don't know it all. So that community learning is important, and it's inspiring to hear about M-Courts today, and also what Dennis is sharing from the work in Ohio about how that mutual learning is just so beneficial and just leads to better coordination. But yeah, just wanted to, I'm going to take the slide. Well, before I take the slides down, I do want to remind everyone for October's meeting, October 15th at 2 o'clock. These are open to the public, so please share as you see fit. Anyone can join. But like Tiffany said earlier, we do just during the Q&A have priority for our council members to be able to ask their questions first, and then we open it up to the public for questions. But I'm going to take my slides down, and we're going to open up the floor for anyone that has questions. I think I saw Lisa's hand first. Yeah.
Hi, everyone. Thank you so much for these excellent presentations. I was really, especially with the M courts, I didn't even know, I know about Care Plus in Passaic County, but I didn't know they were part of this whole collaborative. So I have a question for the M courts team, only because, for us as an advisory committee, I would like to understand first I saw that the RFP came out in 2023 and now you are in 2025, where you're already in implementation mode. Who funds it? Like, is it through the OAG's the OAG, or is it another department? And then how fast did it go from, the RFP coming out to now getting budgets approved, policies and all that to now implementation? Because I see in 2025, you guys are in implementation stage now.
So I can start with the funding. The New Jersey Department of Human Services, through the Division of Mental Health, received a state appropriation to fund M-Courts. And so that funding was used to issue the RFP in 2023. Karen can speak better to the timeline from RFP to actual contract award. And then there were some delays before we launched the service. Karen, do you have the timeline available?
Yeah, I don't have it right in front of me, Renee, but yeah, to your point, right? We published the RFP and then we reviewed proposals through sort of the end of 2023. Awards were made in around January, February of 2024 to 4 of the 5 M-Court provider agencies. And then we issued another RFP so that we could acquire or procure an M-Court provider for Region 9. And that is MHA of Essex and Morris. So it did take some time to get everything processed. But once M-Court was awarded in February, the first 4 providers, they were in process of staffing up, getting things together, getting things moving. And then in short order, MHA Essex and Morris was awarded roughly, I believe, I want to say in September, October. And they really got staffed up quickly. So all MCORT providers were in pretty good position to then finally, once we could go live, and as Renee mentioned, we did have some delays relating to some technical difficulties. But when we did get rolling, we did go live March 3rd, and staffing was picking up. It wasn't completely ready to go 24/7. So we started with hours of weekday hours from 7 to 3 p.m. And then about a month thereafter, we expanded to 7 a.m. to 7 p.m., I believe it was. Ariel can help me out here. And thereafter, then we expanded to weekends, first shift. And then, like I said, this past week, we expanded to full 24/7.
Can I ask a follow-up question, or are you, my follow-up question is, like, right now in the you said March, right, that you guys officially launched?
Yes,
Like,
March 3rd.
do you see, because we are also going to have, not the exact, right, but we're a lot of the advisory group, we're going to be helping to launch a crisis response team that's based from the community, right? Many of us are CVI organizations. Do you see some gaps in the calls that maybe you need further assistance, where you see this gap being filled in by us, organizations like ours that are also going to be launching similar type of crisis response teams?
I'm sorry, you broke up a little bit there. Launching, can you say that again, the end part? I'm so sorry.
Because, from listening to MCORTs, right, especially the peer support type of thing, and then you said people from the community, I know that with our crisis response teams, it's a similar thing, because it is going to be folks from the community that are going to be trained and are going to respond to crises. I'm just wondering, like, how can we work together, because you guys are already in place? That's number one. And number two, what are some gaps you see we can, right? Because I don't think that I don't want to replicate, right? Because, I heard that you guys already have an organization in Passaic and Bergen that serve, which is Care Plus, and I've spoken to Care Plus before. So I just want to know, based on what you're seeing now, how can we support or, further the infrastructure of what's happening and the needs of the community?
Okay, got you. Thank you so much. So MCORT is very specifically accessed by a call to 988, right? And the Lifeline Center crisis counselor talks with the person, assesses that they would benefit from an in-face engagement, and then MCORT, a dispatch is requested. So at that point, MCORT goes out to the person who's agreeing to services, and the clock starts ticking with sort of a 72-hour window, during which MCORT provides that initial crisis stabilization episode, but then they can follow up to 3 times within that 72-hour window. So the objective in that 72 hours is, first and foremost, to stabilize the person as much as possible, divert them from progressing into the deeper end of the system, and provide them resources, linkage to services to maintain them ongoing, make sure they're comfortable, that they have what they need. And then at the end of that 72-hour window, typically the MCORT closes the case. So I think Ariel was able to talk a little bit about how we could foresee there being some dovetailing to the CCRTs at that point within that 72-hour window, since MCORT closes out. But if the CCRT provider is able to kind of continue on, and I'm sorry, I don't know all the details about, your service provision and if you have a time frame of, during which you're actively involved, but that might be something we can explore, and Tiffany can certainly speak further to that as well. Hope that helps.
Thank you. Yeah, because ours is also supposed to be where we respond to crisis, right, immediately. So that's why I just want to make sure, like, as we are planning and having best practices, and if we have other organizations in the mix, how can we communicate so that we're not replicating services? And also, it's not like, okay, somebody called 988, but then the family also called our number, right? And now we're all arriving at the same time and inundating this person, right? So that's what I'm trying to understand.
Got it. Thank you. Thank you. Ariel, do you have some thoughts about that?
Yeah, if I could just jump in. I think a lot of, we obviously have a lot of crisis services throughout the state of New Jersey, and a lot of it is about the access points. Ours is 988, Arrive is 911, screening is through screening. And I'm not sure how CCRTs are necessarily accessed, but I do get phone calls. Again, MHA is very well known in Essex County and Morris County, and we get a lot of phone calls about people just like seeking services, family members. And we're typically at that point guiding them through 988. But if that was something that seemed overwhelming or something that they couldn't, like having to take another step or make another phone call and then that has like another step after that to then get to M-Court. And if they really needed something more immediate, like that might be a time where we'd be like, you know what, there's actually CCRTs here available too, that you can call this number and they can go out immediately. So I think it's all about access points, and that's really what makes like a huge difference in these programs. So I think that's where the piece it might lie of like how we could fill that gap, because you only can reach M-Court through 988. And if that was something that didn't seem reasonable to that person, then we can maybe bounce it to CCRTs.
Okay, I know we're running low on time. But Lisa, hopefully that helped you kind of, yeah. Next we have Michelle.
Yes, I will try to make it quick. I do want to just express my heartfelt appreciation to you, Sydney, and Adrian, or Ariel, I'm sorry, and everyone at DMOS for this program. It was actually making me a little emotional, like on a personal level, having family members that have experienced crises and thinking about like just feeling comfort knowing that this service now exists throughout the entire state. So thank you so much. And also for the, like, really walking through some of the cases were really helpful to get a picture of what it really is looking like. I actually had a bunch of follow-up questions that you've already answered, but one that I wanted to ask is, for the M-Court team, is transport something that M-Courts are able to do if an individual needs to go to the hospital or some other care provider?
Yeah, we do a lot of transporting. Sydney's case where she talked about the hospitalization, we didn't call screening, we didn't call EMS. They took them themselves. They felt safe enough to do that. Obviously, safety permitting, we would transport, but a lot of our job is transporting. We do a lot of referrals to EISS, which is like a mental health urgent care. So we're typically bringing people to almost every dispatch, I feel like, ends up in a transportation to another service to warmly hand them off. So we do a lot of transportation, and would definitely encourage that the clients we're seeing utilize us for that purpose too when they need it.
Thank you so much.
And next we have Tiffany.
Thanks. And Lisa actually asked part of my question, but I did want to just follow up a little bit with particularly Ariel and Dennis, if you have a minute. Just related specifically to community crisis response team. So I think Lisa has already flagged, as we work through the end of this, which is a report that we're going to have to come up with some recommendations. And so I'm asking you, what are your recommendations? And Ariel, I'm going to start with you because I know I'm going to out you completely. So MHA is a really obviously great M-Courts partner. You happen to be a really great Arrive partner as well. So I just wanted to tap you to say, like, in this world that that has M-Courts and Arrive, where are some places that you think a community crisis response team, and whether that's like entry, like maybe it's connection with the community, and maybe it's on the back end, referring additional supports, like as you've been doing this work, where do you see the gaps, and that a CCRT could be really beneficial as we build this ecosystem? And Felicia just like put up the slide of what the ecosystem's starting to look like here in New Jersey. So I'm totally putting you on the spot. Tell us what we should do.
I think, because M-Court is a non-police response, I feel like where the CCRTs really can benefit is like connecting with the Arrive programs, the co-response programs across the street, because we get so many calls, right, of like people that call us a lot and they just like to see us, right, or that don't necessarily meet police response, but then we're going out with police because it went through 911. And if there was a way to divert that from our 911 co-response team going out with police officers, even if they're plainclothes, it's still a police officer there. If we there's plenty of calls that Arrive and co-response get that could potentially be diverted another way. Our teams are talking about M-Court with them and talking about 988, obviously, but now we have another service too and another access point. And I again, like, the more access points to get people help, the better. I don't, having all these services is amazing, and that we can access people in so many different ways. And if that's an easier contact than calling 988 or, than calling 911, then why not? So I think it's just connecting with all the different crisis services and seeing where it's not necessarily like fitting the mold of that specific program, and maybe it fits CCRTs instead.
And I don't know, Dennis, if you had any thoughts from the Ohio perspective.
Thank you. For us, it really, all of these programs, you create them with a vision in mind, and we certainly had that. And now they've evolved into these other things that we had not necessarily anticipated on the front end. So initially, for example, my program really was hyper focused on opioids, and then it became stimulants, and then it became alcoholism, and then it became houseless people, and it became, children of, and families. But I think, to what Sydney was just talking about, I think it's really important for folks to sit down and talk about, and where do our systems overlap, is important is as important as where are those gaps in services, and how can we more effectively work together. And it just takes the right people, or one or two people that have the right attitude about how to facilitate those conversations to getting things really accomplished.
Thank you. Mona Cadena?
Hi, thank you. I'm here as part of the New Jersey Violence Intervention and Prevention Coalition, and I really want to appreciate the discussion today. I really enjoy hearing about MCOR and all of the work in Ohio, and it's really incredible to see what other states are doing on this side. And I also want to lift up that the coalition did send a letter last week to council members, Tiffany, the CSG, Senators McKnight and Sumter, just outlining what we think are serious concerns about the CCRT grant implementation. And so I just wanted to lift up some of the things that were included in the letter, and could speak to some of the benchmarks and best practices that I know you all are working on for the report. I think these serious issues really are central to our response to the responsibilities of the council. As we've heard today, we know that the law requires you to submit an annual report on the pilots. And these meetings are really focused on drafting best practice without really addressing what feels like a big elephant in the room for us, is that the pilots are stalling across the state. It seems like in 4 of the 5 awarded counties. And this really is going to impact the report that is going to be due, the report that's going to be due in 2 years. And so we really think that it's important to acknowledge and fix this problem to really fulfill the mandate of that implementation. And we know that you don't have the authority to control all of the things that lead into the challenges of that implementation, but we're really asking you, we're calling on you as the council charged with oversight to look at those concerns that we outlined in our letter. And we think that will be assistive and supportive as you design those best practices that you need to report on. Our demands really include the release of funds, approving budgets, providing transparency in the high-risk designations, improving communication, and considering no-cost extensions given where we are in the grant cycle. And none of this stuff is new, and all of these things are included in the letter. And so, but we want to include that here today in the public record, because we really believe in this work. We think that New Jersey can be a leader and can continue to be a leader. And we think that you'll have a really critical role in the implementation of the Seabrooks-Washington bill. Like, being a year in, it feels hard to say that, has implementation failed, but the community is watching, and we know lives are on the line. Even just it's so clear with the recent murder, Deborah Terrell, 68-year-old grandmother. She was in a mental health crisis. She was maced, tased, gunned down by the New Brunswick police. Like, we can't afford to delay this anymore. So I just want to implore you, please review the points in our letter, and with the authority that you have, do what you can to support the implementation of this. So thank you so much.
Thank you, Mona. We're moving on to Raquel. I think it's going to be our last question, just given the time.
Thank you. Thank you. Good afternoon, everyone. And again, thank you for the incredible presentations and for the remarks. Real quick, I guess back to the MCORT point. Obviously, you guys are doing tremendous work. I think one of the asks, or just piggyback off of the ask, or maybe saying it more deliberately, is that I think we would really benefit a great deal from seeing like a serious coordinated effort between 911, 988, and the community-led crisis response teams. I would suggest maybe building out a triage system similar to things that we're seeing happening in states like Virginia, where 988 is kind of seen as just like one step of a comprehensive crisis response team. I really appreciate what Ariel said, and I think Dennis echoed it, where he said, essentially there's no ego here, right? It's about getting the team that best serves the need of the individual. But I do want to highlight that one of the things that we are most proud of in our CCRT work is really the holistic support that we provide communities. That is that we're not only engaging with communities on their worst day. These CCRT programs are in community with the people that they serve. They're there at the child pickups at schools. They're at community events and mentoring programs and food distribution and worship. So I do want to just lift up for the record that, where although there are areas of overlapping, what makes the CCRT programs very unique, and what I think we should all lean into, is our unique proximity and how it affords our teams a level of credibility and access to the community that can really make all the difference when someone finds themselves in a state of crisis. So, being that this body is here to support best practices for community-led crisis response teams, it's my hope that there can be some serious degree of coordination between larger state systems like 988 and 911 that can really refer calls when appropriate to teams that are on the ground and ready to serve. So I just wanted to lift that up and thank Mona for raising the point of the implementation concerns.
So Rocky, and I know Felicia, you're gonna wrap up. Anybody who missed the last presentation, I would point everybody to the website. We had the team from OIT on last time talking about the challenges of New Jersey's 911 systems, hundreds of them, and those challenges. But obviously, things like that can definitely, recommendations of that nature can always make it into the report, which is obviously what this council is here to do. But unfortunately, none of us control the 911 system. The benefit of 988 is DHS does control the 988 system. So that they have a one point of entry that is not, well, sort of, Karen's laughing at me about that, but they have a sort of more of a 1 point entry system for that, and not 911. But I just wanted to lift up the fact that all of the testimony gets posted on our website. So just anybody who misses it in the future can always do that. And only because it's my only way of getting in touch with Mona. I'm always happy to talk to our partners at NJVIP. I just didn't have a signatory or an email related, a specific person email, not like the general email. So feel free to reach out to us, and we can talk to all of you and make some time to speak related to the letter, as Felicia always sets out at the beginning of the meeting. There's a specific call for this particular council, but we in OACR are obviously the grantee for them, and happy to talk to you separately about that. So just feel free to reach out. We have not spoken before, but other members of NJVIP and we have. So always feel free to reach out to us. Sorry, didn't mean to hijack that, Felicia.
Oh, no, it's okay. Thank you, Tiffany. And thank you everyone for participating today. This was a great turnout. Thank you for our presenters from MCORS and Dennis. And we'll see you in October. Wishing everyone a great rest of your summer. Take care.
Thanks, Felicia.
Thanks.
Thank you.